Good afternoon. Welcome to the Mechanical Support Devices in the ICU component of your lecture series. My name is Phil Camp. I'm on the Harvard Medical School faculty and in the Division of Thoracic Surgery at Brigham and Women's Hospital. Today we're going to talk about temporary mechanical circulatory support, or MCS, and specifically address the areas of both heart and pulmonary support. I have no conflicts. I will be discussing several products that are either off-label or not yet approved for standard use by FDA. However, I will not be endorsing any specific product. So, learning objectives for this lecture: brief history of MCS, or mechanical circulatory support, and review of the idea of acute MCS. And we're going to look at both the old and new paradigm or perception of how we do this. So if you look at how we used to think of mechanical support, we had lung or heart support, and that came in the variety of either ECMO or ventricular assist device, or VAD. And that paradigm has essentially radically shifted to essentially a spectrum of care that goes anywhere from pure lung support, a traditional ECMO support, all the way over to pure left ventricular support, but more commonly a mixture of both heart and lung support, including biventricular. And so for today, we're going to talk about the global area of mechanical support, which includes heart and lung. Our goals are to talk about both the cardiovascular and respiratory indications. We'll talk about who were candidates. We're going to look at specifically some of the pluses and minuses for each of the modalities. We'll talk about some basics of ICU management in terms of the actual use of the device, and then briefly outcomes and questions at the end. So mechanical circulatory and pulmonal respiratory support is sort of the group area of this type of technology. The primary driver is need and innovation. And the primary area within this area has traditionally been heart failure. There are about 825,000 new cases every year. And there are significant incidents of acute cardiovascular collapse and respiratory failure. So what we've seen are innovative interventions and therapies that have been created essentially to temporarily support and allow for advanced mechanical support, mostly to allow for diagnostic, intervention, and therapeutic aspects on a patient, not just maintaining blood pressure. So if you look at the cardiovascular component, this timeline, which is in your slide set, sort of shows the early 60s into the current era of cardiovascular support, and goes all the way from the first implantable support back in 1963 up into the current era where we have multiple implantable small devices that are used for pure cardiovascular support. In the late 1960s, what you saw was the development of pulmonary support. This graph represents the incidence of ECMO in the years coming from its initial use back in the 60s into the current era. And as you note, there has been a rapid increase in the use of ECMO, or extracorporeal membrane oxygenation, in the use of resuscitation for patients both in pulmonary and cardiovascular diseases. When we look at device paradigms, they come in different basic applications and varieties. We look at extracorporeal pulsatile support, which is becoming less common. We look at implantable continuous flow, which is becoming more common. Implantable pulsatile support, which is becoming much less common. And then percutaneous support, which is something you'll probably see more often in both the medical and cardiac ICUs in terms of supporting patients through transient problems. So why have we been able to see such a dramatic increase in both the pulmonary and cardiac support devices? Well, improved engineering is the primary driver of this. We've seen significant improvement in durability. Originally, devices were designed to last 30 to 90 days. We now are talking years. The flow capacity of devices was originally quite small. We can now do complete support The size has gone from literally requiring a refrigerator compressor pushed around behind the patient for pneumatic devices to now something that sits in the palm of your hand. And then just innovation, how technology has rapidly moved ahead and allowed us to use smaller and better devices. And these developments or improvements have come in a series of different areas. Most everyone is familiar with the intra-aortic balloon pump, probably the longest and most durable devices that we commonly use. You hear the phrase ECMO used, but probably more commonly now we call it extracorporeal life support, or ECLS. And when we think about this, we typically think about lung support, but it's really become cardiovascular. And the device has gone from essentially a monstrosity to very small, elegant devices with very significant and long-term oxygenation devices and very thoughtful and miniaturized cannulas allowing us better access. The percutaneous VADs, examples include the tandem heart and the Impella, come in various sizes and different flow rates and allow for different applications. And then we sort of talk about what is short term, and we'll talk a little bit about that later on. So what we've seen essentially is this revolution from durable mechanical support, which was thought to be really longer term, to an acute and short term mechanical support. And I sort of think of this as an evolution to a spectrum of support that includes both heart and lung. This is an example of a flow chart predominantly looking at heart failure, but I'll show you where it comes in pulmonary. And this is an example where someone presents to your ICU with an example of heart failure. And if they are otherwise stable, you have the conversations of are appropriate for heart transplant, yes or no. If they're in acute cardiogenic shock, which is really when we talk about short-term support, and we don't know their long-term status in terms of what they're a candidate for, a number of options exist, including balloon pump, ECMO, a number of different short-term VAD or Impella devices. And we provide essentially a stabilization of the patient, either allowing us to show that they're appropriate for heart transplant, and then we talk about a longer-term device if necessary. If they're not appropriate for a heart transplant, where we talk about destination therapy and implantable device, or if we think this is a recoverable process, do we bridge them to either recovery or bridge them to a different device? And so we really think of things differently, and nowadays we talk about essentially providing short-term support so that we can have the time to make good decisions about the long-term plan. What are the goals of temporary mechanical circulatory support? Well, we want to augment or replace cardiac output. And the goals, if we are being optimal, include decreasing preload, decreasing afterload, and providing myocardial rest, both the right and left ventricle. In addition, when indicated, we want to augment or replace gas exchange. So we want to improve oxygenation, improve CO2 clearance and pH maintenance, and provide pulmonal vascular rest or lung rest when indicated. And ultimately, in the process of doing this, we want to make sure that we are preserving adequate perfusion and oxygenation to organs. So it's preserving all other end organ function while we're taking care of the usually single organ failure. What are the arenas of support where this kind of mechanical device might be used? Acute injury is probably the most common we think of, an acute coronary syndrome, most common probably in the cath lab, episodes of acute myocarditis, or the setting of cardiac arrest when we have an unknown etiology and it may in fact be reversible given enough time to intervene if we can stabilize the patient. When we think of pure respiratory support, we can talk about aspiration, something moving towards an ARDS kind of picture. We talk about isolated respiratory failure from infection or reactive airway disease. There are many instances where we can bridge somebody who has status and we essentially are unable to ventilate them for a period of time. And there are a number of indications for metabolic poisonings where we can support a patient through a temporary period when they're reversing a known agent. There's also a number of other things on the acute phase that we use this for. In the acute setting of pulmonary embolus, mechanical support is often life-saving. In the rare but often fatal episode of amniotic embolus, this can also be a very important transient support device allowing the mother to survive the event. And surprising to many, there are certain traumatic situations where you end up with severe pulmonary injury secondary to either primary lung problems or a secondary insult, where so long as the bleeding risk is acceptable, you can support someone through that kind of event. When we think of the areas of additional support, we talk about induced injury, so the post-cardiotomy cardiovascular shock or failure, probably one of the more common induced cardiovascular arenas. And then trolley, not uncommon in the OR or in ICUs with large volume resuscitation, also a good area for support. In the setting of post-heart and lung transplant, there is a known episode of organ dysfunction. In lungs, you expect significant dysfunction, according to literature, up to 15% of the time, usually associated with an ischemia reperfusion injury. Being able to bridge that patient through that and not only take up the role of the new but injured lung and provide oxygenated blood to this new graft while it recovers is significantly improves the survival in these patients. In the setting of a heart transplant, it is not unusual to have significant early right ventricular dysfunction after an implant. And in the setting of this kind of problem, allowing the patient to be supported for a short period of time, typically up to 3 days, usually allows the graft to settle in, recover, and allow the heart to take over normal function. And then an interesting problem we've seen in lung transplants are patients with prolonged significant pulmonary hypertension, where the left ventricle has essentially become untrained. When the ventricle becomes suddenly prolifically filled with fluid, its overall function is poor, and sometimes allowing the heart to essentially gradually take over a function over a number of days improves the ability for the patient to tolerate a transplant in the setting of this kind of ventricular dysfunction. And then, of course, for just pure pulmonary failure, there are a number of different significant and complicated lung surgeries that tend to sort of run the sort of fine area of barely doable in a large quaternary center, but the ability to back up that kind of procedure with ECMO while the patient recovers allows for fairly complex surgeries to be performed with relative minimal impact on mortality. We also talk about bridges through therapy or healing. And so in patients who don't need to be replaced but are going to be undergoing either a very complicated procedure or are prone to not tolerating a procedure, we can provide temporary support. So in the example here, coronary stenting or arrhythmia ablation, we can put a device in and allow maintenance of blood pressure and organ perfusion and allow for procedures to the heart with relative impunity and allow the proceduralist to undertake these complex procedures and give them the time they need to accomplish this. Providing stability for pulmonary embolectomy typically is a pre-procedure, although there have been folks who have done the embolectomy in the cath lab for patients who are inappropriate for the OR. And in that setting, giving them support while they undergo embolization or removal of clot can improve outcomes. In addition, there's the unusual or occasional cases where you need full support. So there are patients who, as an example, have pulmonary alveolar proteinosis, and where you literally need to wash out the lungs. You can imagine this can be somewhat complex if you're trying to also make sure they ventilate. You can place that patient on support, fully irrigate out the lungs, cleansing it of the protein debris, and then return them quickly back to lung support with relative impunity. The additional areas of temporary support tend to be sort of more mid-term, and we think of those as bridge to transplants, both for heart and lung. We have temporary and durable ventricular support devices, which we can bridge for hearts. And then for lungs, we have ambulatory ECMO. Let's talk about the individual devices most commonly used and sort of talk about the advantages and uses. The intra-aortic balloon pump rolled out in the 60s, and Dr. Kantorowicz demonstrated survival in shock in 1968. It was subsequently shown to improve hemodynamics, it increased cardiac output, and decreased lactic acidosis, and has been considerably reliable through its lifetime. It is not perfect, but it is certainly a very consistent device. Advantages of the balloon pump are that it decreases left ventricular preload, it decreases left ventricular pressure, it decreases left ventricular wall stress, and with it afterload. As a result, it decreases myocardial oxygen demand, and with that improves coronary blood flow and subsequently systemic blood pressure. So overall, it decreases oxygen consumption. And as a general rule of thumb, doesn't require additional medications or significant anticoagulation, so there's not a lot of side effects of systemic medications that are required for more complex devices. So just a quick picture showing the device in a heart. The balloon is inflated during diastole and is in sync with the closure of the aortic valve. The blood in the aortic arch above the level balloon is pushed backward, providing increased coronary artery blood flow and increased myocardial supply at a point in time when the left ventricle is empty and wall tension is low. And I've always, it finally occurred to me, you see the arrow moving here, the balloon, it doesn't seem that big, but how many cc's are in the left ventricle when it ejects? This balloon tends to be comparable, so really it is a stroke volume worth and is comparable to essentially each heartbeat. So when the balloon deflates just before systole, what you have is a sudden drop of downstream pressure because you've created a space. Afterload radically drops. The balloon creates essentially this empty space where the heart is able to eject into a low pressure environment, and thus the resistance is low and the amount of work the heart has to do to eject blood markedly drops off. Common indications for intra-aortic balloon pump include cardiogenic shock after acute infarction, left ventricular failure in the post-operative cardiac surgery patient, severe unstable angina, post-infarction VSD or mitral regurgitation, short-term bridge to cardiac transplantation, although that's becoming much less common, and then support during high-risk procedures. You've probably all seen this in previous training, the function of the intra-aortic balloon pump. Essentially, the greatest benefit is in those with myocardial ischemia because it allows unloading of the ventricle, decreased wall tension, and improved coronary flow. So if you look at the effects of this particular device, and we're going to compare them as we go through the talk, we do reduce afterload. There is a slight increase in the left ventricular stroke volume. Coronary perfusion does have a slight increase. Left ventricular preload is slightly reduced. The wedge pressure is slightly reduced. And there's no significant increase on peripheral tissue perfusion, but it's maintained. Next grouping is the extracorporeal membrane oxygenation, or ECMO, and more commonly today we really call it extracorporeal life support. So a history of the device, back when it was purely respiratory, 1937, the first heart-lung machine is created by Dr. Gibbons, and first used on humans in 1953. Part of the key was getting gas exchange, and so in '63, the silicone membrane gas exchange device comes along. And in '74, Dr. Drinker and a young resident named Bartlett at the Brigham and Children's in Boston created a study using essentially ECMO as a variant of bypass, and showed it to be successful on children. In 1976, Bartlett did show the first neonatal survivor of ECMO after meconium aspiration syndrome. However, when it was first formally studied in '79, Zappel et al., the results were frankly a disaster. It was an NIH study on adults with ARDS, 90 patients. Conventional therapy had an 8.3% survival. ECMO had a 9.5% survival. And the enrollment was ultimately terminated early due to a lack of increased survival. The problem was there was absolutely no controls of these patients. Who was enrolled, how they were managed was completely unmanaged in the study. And essentially this was an apples and oranges situation. And this is just a chart looking at the survival curves for these two. And as you can see from the bottom two, no difference. And really this was a very damaging study. It effectively ended the use of ECMO in adults for essentially a couple of decades. Now, it's not entirely crazy about why it was not so popular. This is a picture of the first successful ECMO support in an adult patient by Dr. Hill in 1971. And literally, it was almost impossible to get next to the patient to provide patient care. The entire room was full of devices. Part of the technology we mentioned before has really changed this so that it is no longer essentially impossible to do patient care. This is a close-up of a particular device, and you can see here on the right the device, the entire system, including the pumps, the infusion components, the pressure monitoring, a heater cooler. The entire thing is on a small stand at the end of a patient care bed, and functionally doesn't limit other patient care going on in the room. And just in this last decade, the picture to your lower right, you see a gentleman standing in front of a device, and to his right, you see a series of other devices. The entire conglomeration of materials that you see in the larger set essentially is encompassed in the smaller device. And this is a common device now used for both heart and lung support outside of the OR. What is ECMO? It's really fairly simple. You've got a membrane oxygenator, you've got a pump, and you've got some reasonably interesting techniques that we can gain access to the vascular system in a patient. Really, for the most part, that's the entire system. And if you think about the standard alveolar blood interface, the membrane in which the gas exchange occurs is essentially the same basic concept. Blood goes by, gas goes across a membrane, and you normalize. And essentially, we can control respiration and oxygenation by using the FiO2, just like you would in a set of lungs, and by changing the ratio of oxygen and air, and then how fast the gas goes by with the blood, you can change CO2 clearance. And so you can essentially adjust respiration and oxygenation with a combination of how much is being blown by the gas exchange device and how fast it's blowing by. And the pumps have gone from these monsters that were literally the size of a small college refrigerator nowadays to this device. You actually, if you see the shoes up on the picture, this is a patient walking in the hallway, pushing his own device. He's hooked up to this, and he is walking in the hallway, and this is his pump just churning away. The gas exchange devices have markedly changed. Although not currently FDA approved for more than 6 to 8 hours, the polymethylpentene devices that are currently available have provided significant advances. We have been able to get 45 to 50 days out of a single device, and they are highly efficient, so that we can put 5 to 7 liters of blood flow through here and perform very significant gas exchange. There are obviously problems when you take blood and you put it into a large membrane area. You will ultimately make small clots, and you can see this is a washed out circuit where you can see bits and pieces that were flushed into this circuit. In this case, the circuit does help us in that it helps contain these and not send them back out to the patient. So when we first rolled out ECMO years ago, its primary ability was for pure respiratory support. Nowadays, it's combined cardiovascular and respiratory support as indicated. We can be centrally or peripherally interfaced with the patient, and remarkable because of the engineering, literally we can initiate anywhere within a healthcare facility or in Europe outside of a healthcare facility this technology. There are a number of different techniques for gaining vascular access. We're going to look at that briefly. And there are various modes of support that can be provided when interfaced on the patient. And ultimately, most important for patients not having complications of ICU level care, you can mobilize these patients while on full support. So this is two examples of ECMO support. These are both peripheral approaches. One is veno-arterial or VA ECMO to the left. And you can see it's coming out of one femoral vein and going into the other femoral artery. And then the picture to your right is an example of veno-venous or VV ECMO, where we are drawing out from the same femoral vessel, but we're going back into the internal jugular vein so that oxygenated blood essentially is being placed into the right atrium. And the two pictures to the left are sort of pictorial representations of that. And then we can do central cannulation. We can actually cannulate in children, typically in the neck, both venous and arterial. And in adults, we can actually, through an open sternotomy approach, cannulate through a number of different approaches within the sternum and then close it as able. This is an example of that last. This is someone who in the OR required support, could not be weaned from cardiopulmonary bypass. And so essentially we just transitioned them to two different hoses. You'll notice one is dark red and one is bright red. And so here's venous blood draining to the system and being returned into an arterial cannula, probably in this case in the ascending aorta. This is a more common peripheral approach seen. This is the right groin, knee down here. You see that there are two cannula, and what you have is a brighter and darker cannula. So here is the venous drainage cannula. These are very long. This cannula tip is actually sitting in the right atrium. This is an arterial cannula that is allowing flow into the femoral artery, and because we want to make sure we aren't causing blockage and ischemia downstream from this vascular intervention, this second cannula here, the green and white tip, actually is cannulated into that same femoral vessel and going downstream. So if you will, this is piggybacked off of the arterial line so that we have flow down the leg and to the body so we don't have any ischemia. This is a pictorial representation of that same picture we just looked at. Again, allows us fairly good support of a patient without the typical risk of obstructing a blood vessel and not having adequate flow to the limbs. One of the cannulas that has really revolutionized the venous side of support when we only need to do pulmonary support are these dual lumen cannulas. This happens to be an Avalon cannula, but there are a couple different brands out there. And it is a cannula within a cannula. So there is a small cannula inside of this, and then the distal and proximal ports are part of the same larger outer lumen, so that we can collect both blood from the IVC and the SVC, collect it back to the patient, and then once processed, bring it in through this smaller portion inside and eject it here in the mid cannula, which puts it right towards the tricuspid valve and into the right atrium. And this allows essentially capture of typically 70 to 90% of the blood flow. And so near complete treatment of all the venous blood, so that by the time it's hitting the pulmonary vessels, they're seeing fully oxygenated and fully treated blood. This is a larger pictorial representation of that same cannula. You can see the circuit. Again, a pump, an oxygenator, and an interesting device to apply it. And this device has allowed us to take patients who used to need to be flat in bed and walk them, and we'll show you some pictures here. ECMO has radically improved. Essentially, ECMO used to be a death sentence. If you needed ECMO, you were going to die. The first successes were in the neonatal areas, where you saw probably the first and most important work done. There have been, and this is 2015 data, nearly 28,000 kids put on for respiratory support, an additional 6 to 7 for additional. And we're talking survival from respiratory point of view out of the hospital of 75%, and in folks who had complete cardiac collapse, so an expected mortality of 100%, 40+% of these children leave the hospital successfully. In the pediatric volumes, good numbers, not quite as good. Again, it tends to be where they're getting care. In adults, we're not quite as good, but we are remarkable in terms of what we've been able to do. So in respiratory, nearly 60% nationally of the patients who require pure respiratory support will leave the hospital successfully. And for those cardiac patients who needed it for cardiac support in the hospital, where you would expect, again, 100% mortality, 41% leave the hospital. This ECPR, I will talk about briefly afterwards, but note this 28% survival. We will come back to this. So I mentioned ambulatory ECMO earlier. One of the primary problems about being strapped to a large set of cannulas and a device is you don't move around much, and people are uncomfortable about getting you up. That has changed. In our institution, we have a walking program. In the 70s, really wasn't possible. Nowadays, with what we have for the ability, we have larger numbers, and this is the 2010-11 data. It's 56. Currently, there are over 300 people in the country a year who are bridged on walking ECMO. And this is an example. This is one of those similar cannulas we looked at before. You'll notice it's here in the right internal jugular vein. You can, even from here, see bright and dark blood. And you'll notice he is not on a ventilator. They take him for a walk. It takes 4 people to do because you got to move all the device. But this patient is ambulatory and not gaining all the usual sequelae that you would expect someone who is in bed and unable to move while waiting for a transplant. We mentioned earlier high-risk procedural support. A study in 2010 by Shu. Essentially, they looked at patients who were going to require very high-risk interventions. They were in cardiogenic shock. They needed to do interventions. And they looked at those patients who were placed on peripheral ECMO for transient support and those who weren't. And the survival curves are pretty striking. For those patients who were in shock, needed interventions, and were supported with ECMO, we're talking about 30-day survival of 65%, whereas without that, the 30-day survival was, 30-day survival was the same thing as the 10-day survival, which was about 30%. So more than double the survival by taking over the work for the heart and giving the procedural teams time to do the work they had to do. ECPR, so ECMO or ECLS supported cardiovascular arrest. This is not yet a standard of care. It is done in multiple places. It requires a shock team and a very aggressive ECMO team, but it is a very interesting concept, not like all interventions we've done over time as we've gotten better at managing codes. So the after cardiac arrest ECPR, predominantly in hospital. Here's a 2011 study with patients who had in-hospital cardiac arrest. And when you looked at survival in this fairly early study in patients who were placed on support after more than 10 minutes of CPR, the survival was roughly double those who didn't. And this was meaningful, left the hospital cognitively intact. In a more recent updated, where they looked at specifically how long it took to put ECMO on, and they broke it into the less than 30 minutes and more than 30 minutes. 4 patients who arrested and could be on support within 30 minutes, The 50-day survival, as you can see here, is more than 70 and less than 80%, compared to a little over 20% in the patients that it took more than 30 minutes. So access to it and rapid support in the setting of arrest, it was the trick to getting good outcomes. A lot of this, frankly, has to do with supporting the patient while you figure out why they arrested and fixing the problem. There are a number of other studies that are out there. I put these here for your reference, but in general, survival has been quoted anywhere from 20 to 50% in the patients who are supported in similar fashion. There's also some study that's being done for out-of-hospital arrest, and in a couple of different studies, and in at least 2 places in Europe, they're actually initiating ECMO in the street with paramedics, and certainly not a concept that's been embraced yet here in the States, but in the selected patients that had CPR going, they had neurologically intact survival out of the hospital at 3 months of 30% versus 8% in patients who were just brought in without the support. Again, very small studies, very frankly controversial, but the idea is that if you can support the rest of the systems, especially neurologically, that you can give a patient enough time to fix the problem that got them down in the first place. What about mechanical support in sepsis? Interesting study, Critical Care in 2013. They looked at patients who had undergone veno-arterial ECMO, about 200 patients. And in that group, there were 14 who had been placed on due to refractory septic shock, not a common indication in most places. And this was done essentially because there was a question about whether or not they had essentially refractory cardiovascular dysfunction secondary to the bacterial septic shock. And in these 14 patients, they looked at a number of things, including at the time of implantation, what was the left ventricle doing? And again, these were septic shock. This wasn't cardiac arrest. And then with the patient then being supported and recovered, where was their ventricular function? Essentially returned to normal, and then in follow-up maintained. So the idea that you have transient ventricular and respiratory failure, and that supporting somebody through that period, you can essentially return them to normal function instead of driving them with pressors. Of the 14, 10 long-term survivors. Again, small study, certainly needs to be flushed out more, but very provocative. So in the ECMO area, what about an afterload? It increases afterload, and that is a bit of a trick in terms of making sure that if you've got ventricular ejection, you need to manage that. The left ventricular stroke volume is reduced. Coronary perfusion, honestly, it depends on a number of factors. If the left ventricle is empty, it's increased. If the left ventricle is not fully drained, unknown. It does reduce LV preload. It does drop the wedge pressure, and for sure, it improves peripheral tissue perfusion. What about VADs? Well, most of you are not in the cardiovascular area, but these are creeping into all parts of the ICUs that we take care of. This is simply a diagram to show you that there are a lot of different devices out there. And this is simply a graph that looks at continuous versus pulsatile devices and those that require surgical implantation versus a non-operative implantation. And again, in here we've got balloon pump, we've got ECMO, and we've got sort of different middle and long-term devices. And if you look, we've got, spectrum of things that are available. There are a number of other products that are out there. Again, this is not meant to be definitive. It's just there are a whole lot of options. Well, what do you use for device? Part of this is what do you need for support? And so when we think of mechanical circulatory support devices, we think about, the degree of support required. If you look at this graph where we have degree of support and then whether or not it's partial versus full, the balloon pump does improve cardiac index to some degree, estimated 15%. So it improves it, but it is clearly partial support. If you look at a peripherally placed device, a tandem heart as an example, or an Impella 2.5, a CP of 5, you can increase cardiac index 30 to 60%. It is not full support, but they are peripheral devices, and you can get significant improvement overall. To get full support, you need to go either to a CentroMag, an Abiomed, some other, or a larger surgically implanted Impella. Or if you need full support and you need respiratory support, you need to move at least temporarily into ECMO. And these provide 75 to 100% of improvement in cardiac index and do provide full support. Now, everything comes with a trade-off, so you've got your partial and your full support devices, but here's how you have what you need to get in. Sternotomy over here on the left, percutaneous over here on the right. So for the balloon pump, it's pretty easy concept. You get only partial support, but you don't need much for access. On the other end of this, in the full support area, you can use peripheral for ECMO and get respiratory support. Again, it is temporary. And then as we move backwards here, requiring more and more complex surgical approaches, we have smaller and larger Impellas, the tandems, and ultimately we get to CentroMags, Abiomeds, and other devices that require central cannulation typically. So what are the characteristics of an ideal temporary device? It has to be effective, has to provide a wide range of hemodynamic support, full to partial flows as necessary, and has to maximize left ventricular unloading. And that can be a combination of either doing what the balloon pump does, which is creating a downstream void, or making sure that the left ventricle is emptied, and so the wall tension is low and that you have a heart that essentially is decompressed. They need to be flexible with the ability to use in multiple clinical scenarios. So they have to be able to flex up to biventricular support. Characteristics ideally are ease of insertion and ease of removal. If it's possible to support someone and not have multiple operations, better for the patient. Ease of assessing LV recovery. In a lot of these patients that we've described, you need to be able to assess this carefully. If you have an open chest technique, you may not be able to see as easily. You may require transesophageal echo. In an ideal world, minimal anticoagulation. I can tell you that there is no gold standard nationally. There is active debate. We have folks from the Brigham team who have literally helped write the white paper on this. More and more, we're moving towards minimizing the amount of anticoagulation with improved technology, but again, bleeding is still one of the major risks. Permitting patient mobility. This is sort of the key, especially in patients where you're trying to figure out what the next step is. And if you're thinking that you want to get them up and avoid complications, you need to be able to ambulate them and work with physical therapy, occupational therapy. So support needs to support this kind of idea. And more biocompatible. So we have low thromboembolic risks and low hemolysis, which were traditional problems in some of the devices we used. So when you're sitting there and asking yourself, what device do I use? I think you need to sort of think about the patient and clinical scenario. There is no magic answer to any one problem. You need to tailor the therapy and the choice of device to your clinical situation. So in the setting of, say, post-cardiotomy failure, you want to use probably an implantable system. The chest is already open, so you have many options. You could use a CentroMag. You could use a ECMO setup, but with central cannulation. How about post-myocardial infarction, cardiogenic shock? Well, you're in the cath lab. So ideally, you want to think about percutaneous systems, using something like the tandem heart or Impella. If it's myocarditis, you're thinking percutaneous as well, because it's probably going to be temporary. What about high-risk cath lab interventions? Well, although expensive, the Impella has been shown to be a good device for unloading the left ventricle and giving interventionalists more time to complete their procedures. And then high-risk op-cab support. There are good folks who do off-pump surgery, patients who are not good candidates for bypass, where you can support them with devices while you do their bypass. Again, not an ICU issue so much, but patients you might see coming to you who have a device placed for this reason. Again, there is no one system that is superior to all others. You need to look at each clinical situation. And the reason is, with the exclusion of intra-aortic balloon pump, which has been studied extensively, there isn't enough data yet out there that has proved that any one system actually overall improves survival. And as a result, you're really applying technology as best you can. Common pitfalls to temporary support. Well, what you're basically trying to do is provide maximum flow, and you're trying to provide maximum left ventricular decompression, and this is when you're talking about biventricular support. And not uncommonly, if you're doing AV support, so you're pumping into the artery, the heart isn't able to eject well and you don't have good decompression. And when you aren't optimizing decompression, you aren't optimizing recovery. In addition, when the heart doesn't eject well, you have increased problems with thromboembolic risk, and from that, increases of LV thrombus from stasis. So when you look at which of these devices is better for this problem, on the improved LV decompression, apical cannulation, so actually cannulating into the heart with an implantable device, a temporary implant like a Centromag or an Ebumed, putting a catheter across from the right through the septum and or into the mitral valve so that the ventricle is not able to become distended. This does limit the ability to watch and recover somebody while they're cannulated, but it does keep the ventricle decompressed. Or using an Impella-like device where you are physically decompressing the ventricle with a pump. Those that don't do this as well, the indirect unloading tend to be the ECMO, the balloon pump, and the tandem heart, so long as you haven't done a transeptal puncture. So if you're just doing right to left support. I think important, and this shows out here, this is a study in circulation. It's an old one, but it's a good one. Essentially, improved regional myocardial blood flow, left ventricular unloading, and infarct salvage using axial flow transvalvular support. And essentially, when you can keep the ventricle decompressed, you minimize the area of injury and you improve perfusion and improve recovery. So when you compared, and this is again an old study, a balloon pump, which again, still a standard of care, you didn't see a significant change, but when you took and put them on something that actively decompressed the ventricle, you saw a significant improvement in decompression, and with it, you saw improvement in flow and decreased ischemia. So with this, what you ended up seeing is decreased infarct size. So when you're supporting somebody, making sure that the ventricle is decompressed. The tandem heart we talked about before, it is an extracorporeal centrifugal pump. It's an impeller supported with a bearing. It's designed essentially for left ventricular support, so it is a partial support device. It is possible to cut into this circuit an oxygenator and turn this into a biventricular support, but like so many things, that is an off-label use. We do it a lot, but it is not, its primary function. One of the interesting differences in this device is the venous cannula, which you saw a picture of earlier, comes all the way up, and here you create a septostomy and put the cannula tip into the left atrium. So you are essentially taking what is oxygenated blood out of the left atrium and then putting it into the femoral artery down here. It again is designed for temporary support. It is a bridge to recovery or a bridge to additional devices. Effective, but it requires a cath lab and a cardiologist who's comfortable doing transeptal approaches. The Impella we talked about, this is a picture of the 5.0. 5.0 is the liters per minute that it pumps. It is not huge, but not small. It is placed typically with a 5, it's placed through a cut down on a vessel, be it the femoral or sometimes in the upper extremity. The others are possibly placed with percutaneous technique, but if you will look here, there is an inflow area and an outflow area, and this is where the valve sits. So essentially it takes blood from this side, pumps it through the device, out this side. So it allows for decompression of the ventricle. As we've talked about before, it's a partial support device, up to 5 liters. One of the problems with this is that if you don't have consistent filling, you can actually get collapse of ventricle and cavitation, which can be a problem. So it's never completely emptying the ventricle, but it is a good bridge and allows for pretty easy placement. We mentioned the tandem and the impella. The afterlobe in the tandem is increased, which is not optimal, but does improve perfusion. In the impella, it's neutral. All you're doing is taking over essentially ventricular function. Both reduce LV stroke volume. It is unclear about the coronary perfusion. The argument is probably that the impella is most likely to do this. Early studies in a precursing model like the impella did show improved coronary perfusion. Again, the data isn't clear current era. There is reduction in LV preload, reduction in the wedge pressure, and both improve your peripheral tissue perfusion. I just wanted to show you a picture of the Centromag. Again, this is a pump where the pump is outside and typically you're cannulated centrally. It is a small pump attached to a control device. You can literally push this around the hallway. It's a centrifugal design. It is magnetically levitated. This is a distinct advantage in pumps because one of the complications of pumps are clots, and when you have no mechanical components like a bearing, there's no heat and your clotting risk goes down. It can be used for right, left, or biventricular support, although in the setting of biventricular support, if it's a single device, you need to put an oxygenator in the system, or you can put 2 different pumps in separately. It does require operative placement through sternotomy, but is a common device for either bridge to recovery or bridge to decision, meaning seeing what the patient's overall status is before you commit to a destination versus bridge permanent device. I placed this slide in here for you in terms of your reference. It looks at the contraindications and complications for each of these devices. I think it's clear to say that all of them come with significant issues. I think if you look here at the all devices category, you can't use them in patients with peripheral vascular disease. You really can't use them in patients with neurologic issues. It's not clear about the role in sepsis. They all have bleeding and vascular issues. They are obviously infection risks because you have transited the skin. And anytime that you are having blood interface with a foreign object, you are at risk for bleeding complications, with it neurologic injury, probably most commonly embolic injuries to the brain, or if the patient is overly anticoagulated, spontaneous hemorrhage. The common pitfalls in initiating temporary support, first and foremost, is delaying. The most common problem we get is we get called to see a patient, be it the medical or cardiac ICUs, and they have been heroically resuscitating the patient, and now they're going to see if we should try mechanical support. And unfortunately, at that point in time, you've got multi-system dysfunction, and it's really unclear if the patient's appropriate candidate. One of the common issues we will get into is, do we need partial or full support? We often and traditionally would underestimate the degree of support. We're going to add a little support in to help the patient, And when they don't fly, now we're looking at a second procedure to change them to a bigger or more significant device. So often in the sort of newer area, we commit to full support up front and then back off as we need to. Commonly in patients, we don't recognize they have biventricular failure. And this is true both in medical and in cardiovascular patients. Not recognizing that the underlying etiology is not just a single ventricle or left-sided problem. Not recognizing the severity of lung injury. This is very common that we get someone where, if we could just improve their cardiac function, the lungs will somehow get better, and then lo and behold, the lungs blossom, and now we're having to figure out how to do lung support. So again, we have become much more suspect of our patients and will often think about initiating support from a lung point of view earlier. Not looking at vascular injury or the risk of limb ischemia. Traditionally, we would put cannulas in and then see how they did. And we have evolved that to we put in peripheral cannulas downstream when we're using percutaneous techniques, assuming that we're going to have a problem and trying to prevent limb ischemia in all of our patients. And then trying to do something with a device that just wasn't intended to do. So, in summary, for mechanical support for patients, initiating support early when indicated, and this means calling in your peers to have that conversation before you think you really need it. Selecting the device appropriate to the clinical scenario and institutional experience. Identifying an endpoint and clarify transplant status early in the process, both heart and lung. If you're committing to this kind of device, we can keep people along for a long time. The real question is, where are we going with this? No mechanical device should be considered a bridge to nowhere. So it is part of a plan to get us to some place that everyone agrees is reasonable. Always think recovery and maximize all the variables to increase the likelihood of myocardial or lung recovery. And then understanding the pitfalls and limitations relevant to each of the devices and cannulation configurations so that you are optimizing the support for that patient.